So we are going to do half of this panel now and then break and come back because it's a very important aspect of what we do. And what we are going to discuss is the protocol for intravenous sodium magnesium EDTA chelation therapy. And the first question that I have, do you adhere to a specific protocol or do you change the protocol in your clinic in accordance to the patients you see? Robin.
I basically use the standard protocol that we've, been using for 50 years, the standard ABCMT protocol that we were all trained with, the 3-hour, 3 grams or calculated dose.
Dr. Chappell?
Don't vary a whole lot.
I use the basic protocol too, mostly with disodium EDTA with magnesium added to it. Although in the 2 studies that we did, multi-center studies, where we tried to show that the 3-gram dose of EDTA was more effective than the 1.5-gram dose, we couldn't show any difference. So I was convinced to use mostly 1.5 grams, just takes less time, and the results seem to be the same. And then sometimes we add a few additives, like we discussed earlier today, like glutathione or one that hasn't been discussed too much is MSM. And I started using MSM for people with arthritis to help with that, but it also seems to affect the permeability across membranes. So I'm hopeful that maybe that affects the blood-brain barrier some. Certainly it's been shown to go across membranes in the eye. So a lot of times I will use MSM.
And which dosage of MSM did you put in your bottle?
750.
And you mix it with in the same chelation bottle?
Yeah. Mm-hmm. And then the other thing I added, which you mentioned earlier, was the hyaluronic acid, which I don't think too many people do that, but I learned that from Dr. Rudy Falk, who is a cancer surgeon in Canada, who used EDTA very extensively, and he felt that the hyaluronic acid concentrated the EDTA in the form of, in the area where there's growth, such as where the cancers were taking place or plaque was taking place. So I put some of that in, but I don't have any research data to back that up.
Okay. Dr. Gordon?
How much? 3 to 5 cc's, and then if I'm really concerned about it, as many as 15 cc.
Dr. Gordon, do you use a...
I have really focused very largely on what Dr. Bloomer in Switzerland was telling me that I wasn't ready to hear when he first told me that he was using calcium EDTA. And I thought, how crazy is that? Because I really have focused on the fact that as we age, by age 85, the average calcium content in the aorta is 140 times what it was at age 10. But the game changes over time as we practice longer, and vitamin K2 has really come to my consciousness and long-term management of the calcium-magnesium ratio. So I have really chosen to focus on the fact that it is very clear now that the level of lead is so determinant of how long we get to live. And since they have the ability to measure lead in bones at Harvard, and they published that in JAMA, telling you that how soon you go blind or how soon you die of a heart attack is tied to bone lead. And since the IV chelation that we love, because I've had over 200 of them, I love them, doesn't get the lead out, and when we look at doctors' data, we can see evidence that when you gave it as a short-term calcium EDTA, because it's painless, you can tend to give that in 5 minutes instead of 1 to 3 hours. And it seems that at that more rapid infusion, we get more lead for the same amount of time if you use 1.5 or 3
So Dr.
grams.
Gordon, what's your protocol?
So the protocol is the protocol that I share with the 3,000 members of FACT, and I've spelled it out so many details because there's a lot of questions for everybody. Is it safe? What about the kidney function? Are you going to hurt the... So I have anybody that wants the detailed protocol goes to gordonresearch.com. You join FACT, and we spell out calcium EDTA protocol and how we do it. Now, since we're doing it, I love to combine Myers. I love to combine anything with it. I'll combine 10, 50 grams of vitamin C with it. but I'm really in love with the calcium EDTA, and I love the idea of patients getting 1 or 2 a month for life. Because since we don't move it out of bone, but soft tissue stores seem to determine how soon our kidneys fail, how soon our heart fails, how soon our eye fails. I love it as a preventive program, and I have everybody on oral EDTA, as I've been every day of my life for at least 25 years. I take between 1 and 3 grams of oral EDTA.
Dr. Chappell, do you use any calcium EDTA or short IV push?
I use calcium EDTA in challenge tests, but and I don't have any argument with what Gary says, except that the most of the research, other than Dr. Bloomer, has been done on disodium EDTA with magnesium. So if you need research backup for what you're doing, you have that behind you more for the intravenous. Now for the oral, there's lots of research out there for calcium EDTA. So the question is, how important are the different mechanisms there? Because certainly with taking lead out, calcium EDTA is excellent. And there's not as much work with disodium EDTA for taking lead out. Actually, it's not approved for that. However, if you want to get the anticoagulant effect, then using calcium EDTA is not going to reduce the calcium, which starts the cascade of the antiplatelet effect of disodium EDTA. So it's, we really don't know which is the most important mechanism at this point. Just one other thing, and that's the parathyroid mechanism that's been postulated, where you get a decrease in calcium taking the disodium EDTA, which you certainly do. We've had serum calcium, we've measured it right after a treatment. It goes down to like 2. So it can be a scary thing, but you don't get symptoms because there's magnesium in the bottle that compensates for that. But that mechanism doesn't seem to be as important with recent literature. At least I haven't seen anything about that lately. I'd like to know what you think about those mechanisms.
Well, when we look at the big picture, I really am convinced everybody's magnesium deficient. And I think the magnesium-calcium ratio and plugging in your vitamin D and looking at what you do every single day of your life. And I think we're all hypercoagulable. And I think Lester Morrison showed that EDTA tended to make heparin work by mouth. That was published in Nature in 1960. So I take my oral heparin in the form of the sulfated mucopolysaccharide we get out of the ocean, where we spent the $10 million with the Lester Morrison studies. So I really study the concept that I can keep you alive without dying of that clot. I haven't had a patient die of a heart attack or stroke in 20 years. So I'm pretty confident what I can do with the oral approach, because it is lowering the coagulability. But I'm very interested in how healthy you're going to be when you're 80 and 90. And so the vitamin K2 to me is a key part of my personal anti-aging. And I have everybody on K2. But when I'm using that Meyer cocktail and some calcium EDTA, I'm really flushing and getting, I tell everybody, if you wash your car every day, that looks pretty good. But if you simonize it once a month, it looks even better. So I tell everybody, come in once a month and let's do calcium EDTA in the vein, because you're only in 5 minutes. It's painless. And clearly it always seems to provoke some more heavy metal excretion. But I'm looking at the long-term problem is that as a society, all of us are vitamin D deficient, and all of us are magnesium deficient. And all of us tend to be under a lot of stress, a lot of adrenaline we're talking about, and we have to be hypercoagulable. And so I want something that perturbs that gently. And looking at Lester Morrison, who spent $10 million and published 3 books, that's what I built the entire idea of oral chelation on, was thinning the blood. But it took his idea of either form of EDTA worked on getting the benefit of the mucopolysaccharide. Using the Chandler loop on the rabbits, we could stop the hypercoagulability using any form of EDTA. And so I'm looking at getting that. EDTA does so many things on our body. We can't just focus on what it does on lead or on clotting. It alters how other things get used in your body. That was the published in paper in Nature in 1960, which Riker took out the patents on. But those patents ran out. That EDTA makes heparin work by mouth. And you don't have to get heparin from just one source. We found it in the ocean from a carrageenan sulfated polysaccharide. And so knock on wood, it's been 20 years, and I have never had a phone call from any doctor's office saying those 9 pills Dr. Gordon believed in didn't work. But I'm cheating. I'm using primrose oil. I've got the essential fatty acid in the omega-3. So I'm doing the game with phosphatidylserine and ginkgo. I use a lot of stuff because it was based on the studies that Morrison did. I got the privilege. Morrison spoke to ACAM, and he told us that he had reduced heart attack rate 91% with the Institute formula. And everybody got up and walked into lunch. I sat down and said, "What do you mean you're doing it by mouth?" And I never left his side because I like IVs. It's fine, but I can't get everybody to come in for an IV.
Doctor, you have
I just have a question for Gary. Do you put, when you say you combine it with a Myers, do you run 2 separate bags, or do you
Great question.
do one as a push, or do you put them all together?
That's why I've asked people to seriously go to Gordon Research, join FACT, because with 3,000 people doing it different ways in different countries, it's whatever works for you.
And by the way, I want to give a plug for Fact Forum. I've been on it for several years now, and it's just such a useful tool. If you have a question, everybody's sharing. You can search it. If you're not on the Fact Forum, go join.
Please join. Go to Gordon Research because you have 3,000 doctors who answer questions to each other. You don't have to live in hotels like I do. And so instead of living in a hotel, you can type in a question, say, "What do you think of injectable vitamin D?" And your colleagues will spill it out. And so you can start to look at it. But if we look at how do you do the Myers and the other things, it has to be based on the economics of your practice, how big your staff is, different things. Let's face it, in certain practices, the patient winds up self-administering their Myers because you don't have a big staff. You give them a syringe and they put their Myers. You have to do what works for you. And so the idea is that whether you do a small mini bag and put the calcium EDTA with the Myers, or you do them separately, and whether you charge separately or not. I have a lot of doctors who frankly use our standard chelation protocol, but they substitute with calcium EDTA, which thank heavens is painless. And so they can run that through in 10, 15, 20 minutes, and now the patient doesn't feel they've lost half a day at work, and they don't mind coming in once a month. I'm really into life extension. I feel great at 77. I haven't felt this good my whole life, and I want everybody to feel as good as I do. But in order to do that good, you have to keep them alive.
So the next question that I have, I guess we went over the short IV push and so on, is that do you ever use the T.C. McDaniel's anion surfactant therapy? And I don't have any experience,
I don't have any experience either.
I can answer to that because I do use it sometimes.
And what does it consist of?
And basically, T.C. McDaniels did not call it chelation therapy. He called it anionic surfactant therapy. And it was combined with a diet that was very alkaline as well. And in fact, a surfactant diet. So the whole idea was to make everything in the body more slippery. And he used EDTA with magnesium and nothing else in the bottle. And he went through, even with disodium EDTA, he went through over like a 15-minute IV, but you had to drink at least a pint of water
During the time.
beforehand and during the time. So he made sure that the body had plenty of water, and he never ran into any trouble with kidney function with that.
I was confused because I know the sodium EDTA protocol, and then I was talking to Dr. Quigg. He said you can never defend using sodium EDTA for chelating lead. You have to use calcium EDTA. So since then we switched to calcium EDTA. But I hear that you guys are still using sodium EDTA for the whole chelation. So give me the pros and cons other than just being quick. The other pros and cons of sodium EDTA versus calcium EDTA?
Well, I love the sodium EDTA if I have a patient whose main concern is pathologic calcification of the valves. And so when I'm dealing with pathologic, I love the tripling of parathyroid hormone. So I still think that we need it there. But of course, my interest in them put them on vitamin K2. But there's always room for both protocols. But the idea that I want everybody to understand is that Caltech, we had Claire Patterson speak to the ACAM twice. And he's at Caltech, and he's the guy that drilled down the Arctic and the Antarctic and found when the lead came into our bodies and published that at birth, the average person on Earth today at birth has 1,000 times the level of bone lead that we had 700 years ago. So since that's clearly relevant to how long you get to live, and since the IV doesn't do it, I think we have to be on something every day like zeolite, fiber, high-dose C, oral care, anything to help not... Because as women go through menopause, they get hypertensive because that's when they release the lead from their bones. So there's times that the bone loss is releasing lead, and you've got to be on something like zeolite, high-dose oral chelate. So I'm looking at the long-term program. But I love to keep the level of lead in our soft tissues as low as possible, so that's when I want the short. And since we're always going to be breathing lead, you can't breathe anything without getting lead.
So
I like the idea.
When will you use the calcium EDTA? If you mostly use sodium EDTA, when will you use the calcium
Okay,
EDTA?
no, I said I only use sodium EDTA only with people whose pathologic calcification
that's
is
the only-
why they came to me.
I see.
That means that's 1 out of 100.
Cardiovascular disease or
For
cardiovascular disease? You
Yeah,
mean
yeah, right.
pathologic?
Right. The only patients that are going to get the IV disodium from me are patients who really walk in and say, I've got this high calcium score, I'm really frightened of it, you can see the calcification on my... The people who approach me for pathologic calcification
Means
are going
atherosclerosis. A
Yeah.
patient with established atherosclerosis, that's will use sodium EDTA.
Let's change that slightly. Everybody, in my estimation, from all this autopsy studies has atherosclerosis.
Okay, yeah.
And so my standard protocol is I cancel bypass on every patient. I have never had a patient embarrass me by dying on my program, so I'm pretty cocky. And I cancel, I don't care if you have 90% blocked LAD and 70% blocked LAD, I cancel surgery because it's published by the American Heart Association in the book by Fuster, the former president, that whenever you see a blockage on a coronary artery, usually it's collateralized. And without a PET scan, you have no proof the patient needs surgery. So I don't do surgery on anybody because people don't want to write a check out for $2,500 for the PET scan. And without a PET scan, you're not justified to cut them open on that. I am very opposed to the surgery. Since I have 0 death rate, I can be pretty cocky.
Including the stents? Including the stents? You're opposed to surgery, that includes stents also?
The stents to me are a waste of time and money. I don't do stenting. I don't do...
So I like to now, we need to break for lunch.
Okay.
I like to have one more comment to finalize, and then I will call you back
Good.
after the break.
By way of a personal anecdote, and I'll keep it really short, in 1992, 93, I developed chronic fatigue syndrome so severe that I was working 1 day a week and barely making it. I would have been 100% retired right now if it wasn't for magnesium disodium EDTA, removing the lead, cadmium, and mercury, and it was life-saving with the very first treatment. It turned my life around. So I know they chelate. I know that disodium will chelate metals. I know that personally, and I've seen it on plenty of patients. Now, is that substantiated in the literature, which is what David Quigg is referring to? Probably not, but I know from a personal point of view that absolutely it does.